السلام عليكم ورحمة الله وبركاته. الحمد لله رب العالمين والعاقبة للمتقين والصلاة والسلام على أشرف الأنبياء والمرسلين وعلى آله وصحبه أجمعين. Jazakallah khairan for coming and bringing the snow, inshallah ta'ala. For those who don't know me, I'm Aasim Padela. I am a local resident here at Aasim Brookfield for now almost 3.5 years, alhamdulillah. And it's my pleasure to be invited by the Masjid Board to present a somewhat controversial topic in a nuanced fashion, inshallah ta'ala, over this Friday today and then 2 weeks from now, inshallah ta'ala. And so I'm going to get into it. I would like to, before I start, make a brief dua. Allahumma alimna bima yanfa'una wa anfa'na bima tu'allimuna wa zidna bi fadlika ilman wa ta'liman innaka ala kulli shay'in qadir. May Allah SWT increase us in knowledge and understanding. So to begin, Jazakallah khair for braving. Now, one more thing I'll say before I start, that there will be moments when I'm going to ask you questions, so this will be a little bit interactive, but there'll be moments for that. So if you have a question, you can hold it until I get you those moments, inshallah ta'ala. But this program is designed for several aims, right? So the first aim is to increase us in knowledge around organ donation, the processes and types of that, the medical benefits and risks of organ donation, the Islamic perspectives for and against organ donation, and to give you a good sense of the difference in decisional context between organ donation and transplantation. They're not the same thing. I'm sure you know that experientially for those who have been involved in those contexts. But sometimes you neglect to think about that there are different decisions that have to be made because the context is different. And my hope for you all as we go through this, or in this, obviously this two-part session, is to motivate you all to have conversations at home about values, beliefs, and preferences regarding organ donation, to prevent ethical conflict at moments of crisis. There can be crises around end-of-life care and organ donation. They're actually connected in an interesting way. And I hope to empower you to make decisions that are informed regarding this topic, right, organ donation and end-of-life care. So this is how the program will be laid out. I know people are here today. I want to suggest that you will leave here today with some understandings, but not full understandings, and you'll probably have a lot of questions. And so I do encourage you to mark off your date 2 weeks from now so that we can close the program with those gaps in knowledge filled in. But today is going to be about the whys, the whats, and hows of organ donation. And then 2 weeks from now, it's going to be about the Islamic responses to that context, the rationale and rulings. Now you might ask, why am I doing it this way? Well, I'm doing it this way because oftentimes Muslim scholars are responding to the context that's existing, right? That they're asked a question in the context of a scenario that's occurring outside of the house of Islam, so to speak, right? In the medical arena. And oftentimes that question is posed, at least in the medical realm, from a physician who's another liaison, right, who might face a challenge but is a liaison for a patient community or a patient that they're facing, and then they're bringing that to it as an Islamic scholar for them to opine on what they should or should not do. And oftentimes that occurs in the context of a fatwa, right? And we all seek fatwa through our lives for various things. But you'll hear from me that actually that is a simplistic one-level response to a larger context that demands deeper thinking. That medical fiqh and fatwa are not sufficient to address the realities that are forcing these questions. Rather, what we need is a more comprehensive understanding from our tradition, not just the legal understanding, but other understandings. I'll get to this later on, particularly 2 weeks from now, that beyond fiqh we need to think about usul and kalam and adab and akhlaq, that a holistic view of Islamic morality is needed to tackle the challenges that are emerging from the clinical practice domain or the health policy domain, so that we can actually truly furnish an Islamic bioethical response, not just a fatwa for a specific context, for a specific patient encounter. And that to do it for society then, beyond us, we must engage with social scientific, biomedical, and contemporary philosophy and ethical understandings. We must engage with the world and the way they think about things, because those are the values that are impressing upon us questions, right? Those values impress upon us questions, right? We didn't decide that when you sign up for your license at the age of 16 in this state, that you're asked about organ donation. Did some Muslim scholars say that's what we should be doing? No, the context and the values of society did that. And then we're forced to have our children to think about that. They might not think about it. They want to be glib about it. But the reality is, if they thought yes or no quickly at the 5 seconds at the Secretary of State, that there will be ramifications upon what happens should they fall into a car accident. The context decides the questions that are important to them and the formula by which they address them. Muslim scholars are responding. My point, right? So we're going to talk about the context today so that we can have a better conversation about what Islamic responses are. I'm going to go over this very briefly. You all know that I spend a lot of time, alhamdulillah, in thinking about these things that have a sort of a dual literacy within the Islamic tradition and medicine. As you know, I spent some time in the Darul Uloom. Many of you know me very personally, so I won't go through this. And I spent some time studying Arabic at the University of the American University of Cairo. I spent a couple of stints at the Oxford Center for Islamic Studies at Oxford, studying Islamic law and theology. And then I've continued my studies in various institutes, thinking about how to engage with particularly medical domain through the Islamic tradition, both usul al-fiqh and fiqh. And then obviously I'm a physician. I say that obviously, but maybe some of you don't know me. I studied medicine at Cornell. I have a degree in biomedical engineering. And then I spent my residency in emergency medicine. Thereafter, I spent time at the University of Michigan thinking about how to address healthcare disparities amongst Muslim communities. So that's the other part of my training. But we can talk about that. I spent time as a fellow at the Ethics Center, so I do provide clinical ethics case consultations as well. If you have questions, but I'm just sending that there is some literacy here. If you have questions, certainly we can talk about that later, and you might feel free to challenge me if there are questions that you have. This program here at this masjid, it comes in partnership with the Initiative of Islamic Medicine, which I am the director of, and that program, that initiative is designed to address these sorts of issues at the intersection of the Islamic tradition and biomedicine, that we want to design religiously tailored evidence-based educational programs that empower people like you, community members, to make informed ethical decisions and enhance community health. We want to develop policy recommendations that incorporate our values, right? So the healthcare system can meet ours and we can achieve health equity. But importantly, for those of you who are related to the healthcare system and are physicians, we want to curate, cultivate, and train a generation of Muslim clinicians, chaplains, religious leaders to instill hikmah in healthcare, right? We are missing wisdom. The healthcare system is capitalistic, consumeristic, and I think that we can inject hikmah within that system. So the preamble is that what you have today and 2 weeks from now is based on a program that took 10 years to develop at the Initiative of Islamic Medicine, 10 years. And it led to this. We had religiously tailored and ethically balanced workshops at masjids, right, with a large team. We had funding from HRSA. We partnered with the National Kidney Foundation in Illinois, and I say that because some of the slides you'll see later on today, you'll say, why is the background changing? Because we actually had partnered slides and different people were giving these presentations. And the gift of hope and then Initiative of Islamic Medicine. So what we did was this. We spent from 2011 to 2021, we spent time in masjids, participating in conversations with religious think tanks and OPOs, and we gathered what the community values were around this tricky topic, tried to understand what the myths and understandings were, what the beliefs were within the community, whether or not there was a disparity amongst organ donation attitudes amongst Muslim communities in the States or not. And then we did analysis of religious discourse. So we spent time with fuqaha and ulama and the fatawa and did that reading, then to design a program, right? Which was proven to be efficacious through, for those in physicians, right? Randomized controlled trial, that's what we did. And 4 masjids, right? And that led to, and I'll show you in a second, increased knowledge and behavioral intent. So, but this context, so the program, and I'll say it again, that program that we did, the RCT, was 2 workshops, 2 half-day workshops. So about 6 hours of a workshop. What you're gonna get from me in 3 hours are some highlights. I typically feel that masajid like to have this conversation like this, right? I say something to you, you listen, okay, did I get it? I don't know if I got it, let's move on. We like to have these lectures. But those workshops weren't intended that way. And the efficacy was not in that modality. It was, yes, we had experts speaking, you'll see in a second. We spoke, then we had conversations. And when you concretize knowledge, it's by having a conversation and thinking about it, right? In case scenarios, not just by a scholar or someone telling you what to think. And so, but given that that is not our modality, we don't have a workshop, I don't have 6 hours, and I don't have people with me, we're going to do this didactic style, I'll try to inject some conversation within it. But the problem that we tried to address was the following. This is what the Muslim community has been doing in the diaspora, in the UK, and to some extent in the United States, where we have noticed, and others have noticed, stakeholders, right, that Muslims have low support for organ donation, right? I'll share data with you if you like in a second. But that's what they've noticed, right? That Muslims don't sign up to be organ donors, whether living or deceased. And so what we need to do then is to kind of think about why. And if you're Muslims and not doing something, they say, what's the problem? Islam's the problem, right? So then what people have been doing is then, okay, let's go to the Islamic scholars and tell them why organ donation is such a great thing, why it's necessary, and then get them enlisted to help encourage that on the pulpit, within their fatwas, or so on and so forth, with the hope that the number of Muslim organ donors would increase. That's the logic train behind what has been the modality of intervention from policymakers in the UK, and actually there was also an initiative in the United States a few years ago. This is one which led to a fatwa in 1995, but in 2019, the same thing happened again, where another new fatwa. Hey, the issue is Muslims aren't doing something, Islam's a problem, get some scholars, read your fatwa, and there you go, you're gonna have change. But when they looked at this, there was actually no change in the organ donation rates amongst Muslims. And part of the problem was that Muslims in the UK, they had high rates, which is similar here, of organ failure, and they had difficult matching, right? They had some particular HLA type matching issues. So the Muslim community was being harmed, and their solution was just fatwas, and the fatwas actually didn't change much on the ground. In the United States, this is the background data. 95% or more of Americans support organ donation. Over half are willing to donate their organs while living. Okay? The Muslim American rates from our work is this. 39% support deceased donation after death, and only 40% believe Islam thinks it's permissible. Right? This is from our own work in those communities, right? So that is a disparity. There's a disparity between belief in the common system and what Muslims are, which leads to some interesting dynamics in the hospital setting. As I said, ethical conflicts that occur, cultural values at stake. So the program that we did was based on this other logic, right? And I'm sharing this with you because when I do these programs, people say Aasim is going to be here as a spokesperson to get us to sign up, and that is actually not at all any aim of mine. The aim of ours is the following: to figure out this logic train. First of all, organ donation is multifactorial and nuanced. It's not one thing. It's not one size fits all. That's our goal today, to show you that it's not one size fits all. Therefore, a singular fatwa doesn't do much. Okay? That if you say Islam is a factor, Islam is not one thing either. Islamic verdicts aren't singular, they're multiple. It's a plural tradition. Any issue that has ijtihad within it will then have multiple viewpoints from scholars, right? And the Muslim communities, their issue is not religious permissibility. There are many other issues that play a role in how they think about organ donation. Fatwas are not theory-driven, data-based, or ethically robust. Having been a consultant for even our own fiqh council in North America, that is truly the case. They're not theory-driven, they're not data-based, they're not ethically robust. And so they cannot be solutions by themselves. And then if we think about the number of donors want to increase, right, as I said, that's what people come in for. Actually, that's what funders want. Our goal, and the National Islam Medicine goal, is that's not the most ethically justifiable outcome. Rather, it's you can make an informed choice, right? That's it. If we can help you feel prepared to make a choice, or for yourselves or for a loved one, then we have accomplished our task. So that was the trial that we did in two settings, Chicago and DC. And the program that we've truncated was much more involved. It involved a khutbah, it involved lectures, as I mentioned to you, didactic lectures from biomedical, procedural, and religious knowledge, and then it involved these discussions. We're only going to have the middle part today, and the middle part's only delivered by me, meaning today and 2 weeks from now. So if you want more, all of this, actually that whole program is available online on our website. All of it, the whole thing, right? So let me share with you some data for a second. And I've only had, you don't need to worry about all this. I just want to tell you that RCT that we did, we touched 800 something people to be involved, right? And when we came down, we gave them money to come. I want you to see this. How many people didn't show up? 200. Now, I had $900,000 of funding from the government to do this. When you see this, that 800 people, 400 or so are going to show up, half of them don't show up, I want you to think of what that means about wanting to invest in the Muslim community ever again for research. Yeah? If I were in any church in Milwaukee, this wouldn't be the case. I'm sharing this with you because, first of all, it's hard to get funding. I have lived my life, but we are better ethically when people invite us to do things. Huh? So mashallah, you all came on time. This was all filler. Mashallah, you came on time. But truly, we have a problem as a community to show our ethical values for even things like this when someone's doing it. So this was one piece of my own catharsis here. And the other thing was that you'll see here, for those who are interested, we actually had knowledge gain across measures. So I just wanted to show that. But our question wasn't about donation, was about preparedness, the top one. We want you to be prepared. So if I do this well, in this adaptation, you'll leave, inshallah ta'ala, 2 weeks from now, more prepared to make a decision and then thinking about how to encourage others who are facing this choice, what to do. There's a pamphlet back there. My daughters are manning that table. It's an organization pamphlet, and your masjid, mashallah, sponsored printing this out. This pamphlet is a tailored and balanced pamphlet that was drawn upon the questions and the discussions that happened at those workshops. So after each workshop, we had discussion sessions, questions that were asked. We then created a narrative and a scenario that would address those questions. That's free for you to take. You can donate to the masjid because the masjid people paid for it. But it was based on data from Muslim communities, okay? So I want you to take that home. I would rather you have conversations around it than just think, okay, I already got it. I don't need to spend the next 2 weeks coming here. And that pamphlet was then also approved by the Fiqh Council of North America, meaning what was in there was all checked, okay? There are a couple articles also that are for free for you to take. So I had interns working with me, medical students. They synopsized fatwas and the programs and put these public articles in ISNA Horizons. You can take them. I printed some out for you. They talk about different aspects of things that then I want to speak about, but it is beneficial, inshallah, please take it. And as I mentioned, the whole thing is online if you want. If I wasn't clear enough, you'll get the people who actually delivered the workshops. And this fatwa from FICNA, so we participated in developing that new fatwa from the Fiqh Council of North America. I will go over it 2 weeks from now, inshallah ta'ala. So I want you to, you'll have some homework to look up at the fatwa because we're going to go through it in detail, inshallah. It's particular to the American context, okay? There's some specific issues within it, okay? Future-wise, we'll talk about that later. So let's begin. Now I have an hour. This is great, alhamdulillah. I will spend 45 minutes speaking, I hope. A few minutes before Isha, we will stop, and then we'll have questions. Okay. So the different whys, whats, and hows of organ donation, okay? So first thing, organ donation is not one size fits all. And this slide that I'm going to share with you, I know we don't have paper and stuff, I want you to just think about the terms that I'm going to use because this is important as you face the decisions, right? So there's a differentiation between living and deceased donation in the United States, right? Living and deceased. And in the United States, that's based on the notion of brain death. I've put it in quotes because we want to get through this in 2 weeks from now, that's a very tricky concept. And many people misunderstand what it is, both from the religious lens and the biomedical lens. So that's one thing, right? Organ donation is not one thing, it's two different things, at least from this side. It's the living and deceased. And then there's also this notion of donation after cardiac death versus donation after brain death. There are different processes involved. So it's not just living and deceased now. The processes involved in the procurement of organs from those different pathways are different, and they have their own ethical issues. All right? So that's one nuance. Two, there's a notion of directed versus non-directed donation. Directed means I want to direct my organ, should I donate it to a loved one? When you're living, you say, my brother-in-law, God for whoever, right? Even when you're deceased, you can do that. You can say, I would like to have my organ go to my family first, then my masjid community first, then my city first, and then it can go out. You can direct it wherever you like to whatever restriction you like. Many people don't know that, right? And the Jewish community does this in their forms, that it has to go to this first, then that first, then if not, then it can go to anybody after that. So directed versus non-directed, right? That's another division within organ donation. You have life-enhancing and life-preserving. Life-enhancing, having a cornea so you can see better, is life-enhancing organ donation. Huh? Someone donated a cornea. Life preserving, I have a bad kidney failure. I'm on dialysis. Dialysis takes 3 times a week, so many hours. I'd rather have a transplant. It's life enhancing. Okay? I am on dialysis. Dialysis is no longer working. Life giving. Right? If you're having too many complications. Organ donation is not the same thing. Organ transplantation is not the same thing. So life enhancing, life preserving, life giving. Different things, different contexts. All right? Okay. Now, one can have organ donation and can just be the organ. It can be the organ plus tissues. It can be the organ plus tissues and vessels. So there's things called vascular composite allografts. You can donate your face or your hand or your uterus. It's organs plus tissues plus vessels. Or it can just be an organ. I'm going to just donate the kidney. Or it could just be tissue. I'm just going to have a tissue graft, right? From one part of my body to another part of my body. It's an autograft, but that's what I'm doing, just donating tissue from one part to another part. So there's more complication. All right, so that's all about organ donation. It's not one thing, it's multiple things, multiple different decision trees. And I'm sharing this with you because when you say, okay, the fatwa says organ donation is okay, I want you to think about what they're talking about because there are many different nuances of what it might mean in your clinical scenario. Right? And sometimes the fuqaha are not talked about the particularistic nature of what we're talking about. There's a general ruling, doesn't necessarily apply to this specific case. Okay, now on the other side, there's this notion of consent, which is better thought about as authorization. Okay? So you can have first person. What does first person consent mean? I, myself, have consented to something, but rather it should be I have authorized something to be done to my body. I'm cut it into it, give the kidney, whatever, right? Whether I'm living or dead. So it's first person authorization, or it's surrogate family authorization. God forbid, one of your loved ones dies and you're there, they're going to look whether they gave first person authorization on the back of their card or in their donor registry, or they're going to ask the family member, organ donation or no, yes or no. It's required by law. Every death in the United States, the question of whether their person's an organ donor is asked, and if you don't know, then you ask the family. That's part of law requirement. It could be too late till you find a family member, then they're not qualified to be an organ donor, fine. But every death in the United States has to be asked. All right? Then there's this notion of presumed. So presumed is a policy that it hasn't been enacted in the United States, but there's a push towards it. The UK enacted presumed consent. Any citizen in the UK is presumed to give consent for organ donation. Period. Because that's the value of society. So if you were to fall and die from a head injury or have a car accident, you're presumed to automatically, default-wise, have given consent to be an organ donor. Unless you specifically opted out in the registry that I don't want to be an organ donor. This is similar in Spain, okay? And there are pushes to do that in the United States as well, hasn't passed. But the cultural dynamic is in Western countries is that presumed consent, okay, or implicit consent, deemed consent, which then would require the burden on someone who's not for that to then say, I don't want to be part of that. Okay, so now organ donation is not one thing, but you see now even consent is not one thing. It means different things in the context. So now when you read a fatwa, what is the context it's responding to? Is it responding to a context of presumed consent, implied consent, first person authorization, family surrogate decision making? Which one is it? So we all want a fatwa. Why fatwas don't work is because of this. It's not one thing. It's a gazillion things, all in one. So the better modality is to educate communities about all of this, okay? And that's why we're here, okay? But I want you to know this is a decision tree that you'll have to think about making. And there are obviously different decision contexts. All right, so let's start with the why. Why organ donation is a real interesting push in the United States. This is data, I looked it up today actually. So there are over 100,000 people who are awaiting organ transplantation in the United States, 100,000, right? 17 people die every day because they're on the list and they haven't found a donor for them. In the United States, how many donations occur? You look at the disparity, right? So there are about 23,000 people last year who donated their organs. And obviously, well, not obviously, but one person who's a donor can donate many different organs. And that allowed for about 46,000 transplants in the United States. So 103 people need, maximum you have 6,000, right? So about half. So this is the context within which the United States and other countries are worried about people dying. This is why they want to have organ donation be more prevalent in the country, all right? Now, most of those organ sort of people on organ transplantation waiting lists are waiting for kidneys, 83%. Right, so that's the most commonly necessary, needed organ, and the most commonly transplanted organ. What do the kidneys do? And for those who are physicians, this might be a review from med school, but what do the kidneys do? Yeah, they make urine, but they do much more than make urine, right? They help make your red blood cells. That's why you're anemic if you have kidney failure, right? They help regulate your blood pressure. So this is a big problem because people say, hey, I have high blood pressure, I haven't taken care of it, but that's going to lead to kidney failure, right? They keep your body acid and regulate that. They regulate the minerals in your body, and they control how much water is in your body, your weight. So the kidneys do much more than just filter toxins in the common way and then excrete it through the urine. They do much more than that. Our technologies to replace kidneys don't do all those functions. They cannot replicate all those functions. They can do what I just said, remove the toxins and urine, so to speak. All right, so but in the United States, and as in most industrialized nations, chronic kidney disease is on the rise, right? So 48 million, so what is that? It's 18% of the population have chronic kidney disease in the United States. It's most commonly caused by diabetes and high blood pressure, right? And 700,000 people in the United States, right, presently have end-stage renal disease, meaning that the kidneys are failed, right? That they have to have renal replacement therapy. And that leads to obviously poor quality of life and survival. What about Muslim community? Muslims are higher risk for kidney disease than the general US population. Arab Americans have higher risk of high blood pressure. South Asian Americans have higher risk of diabetes. And African Americans have a higher risk of diabetes and high blood pressure. So you tell me, are we at higher risk for kidney failure or not? The answer is yes. If we're at higher risk for kidney failure, then the problem of the demand-supply mismatch is more pertinent to our community. And because of our status as different minorities and ethnicities, finding matches is also more problematic. Yeah? So it's not a nefarious thing that our community struggles. We probably don't know, but those who are physicians know a lot of community struggles with this problem, particularly of kidney failure because of our high risk of high blood pressure and diabetes. So as I mentioned to you, what happens if you have kidney failure? Well, there are many things, alhamdulillah, that Allah has allowed us to do. We can have dialysis. It can be a machine-mediated, right? Or it could be peritoneal dialysis. Right? Those of you, right? So you can instill fluids within your peritoneum and drain it in the night, many hours, or you can go hook up to a machine 3 times a week, and they do blood-filtered dialysis. So that's one solution. That solution only provides partial functioning of the kidney that your normal kidney does. A transplanted kidney would provide all of those things. That's why that solution is oftentimes what people go for. Then more recently, we've had this phenomenon of xenotransplantation, right? That donor, that we can cultivate kidneys that are matched and don't have the same immunogenicity as pig kidneys, because we get rid of some of the factors, and then we can potentially transplant them into human beings. Now this is emerging, clinical trials are occurring around the world for this phenomenon, so that maybe that will be a solution in the future. There are some other Islamic ethical issues there, but the point is that is now a real possibility as opposed to transplantation. But presently, those other 3 modalities are what are used. Most commonly it is dialysis 3 times a week through the blood, right, not peritoneal. So that's the why. People have our community has high blood pressure, a lot of diabetes, high risk of kidney failure. Dialysis is only a partial solution. Sometimes it ain't a solution for people who have particularly difficult morbidities, right? And that's why there's a push, generally speaking, in the United States and within our communities. Now, what's the how? As I mentioned, organ donation is not one thing, it's multiple things. Organ procurement, there is is also multiple things, right? So there are living donors, and that process is very different than a deceased donor. So living donor you decide yourself to be tested. Perhaps it's a family member who needs a kidney or something else, and you say, let me get tested. So you get tested. They're usually friends or relatives, right? Not Facebook friends, but real friends or relatives. And then you go and get tested and see if you're a match. That happens in the context of a transplantation center. If that person then is deemed a match and is medically cleared, they can potentially proceed to have a donation or give their part of their kidney, part of their liver, if they would like, okay? And each transplantation center, if you go online, you can find out the rates of success of that donation. Meaning, what is the risk if I were to go and give my kidney at UW-Madison versus some other center? You can find that online. They have to publish this transparently, so you can know your risk if you're going to donate your kidney, right? Oftentimes, the loved one is part of one transplantation center. It could be signed up at multiple different ones, and you figure that out. But it's a different process for living donors. The important point is what I've highlighted here, that every transplantation center must have a living donor advocate, nurse or physician, sometimes social worker. And the people who are part of our project, Dr. Milla Sanders, who gave this talk, that was her role at the University of Chicago. The role of that person is what it says. They're an advocate for the donor. Meaning that if there's a medical reason that they shouldn't donate, if there's a higher risk, they'll tell you shouldn't donate, they'll recommend you don't donate. They have to make sure that you are free and clear and not being coerced to donate. Sometimes there are cases, I told you I do work as an ethics consultant, where family members are being pressured to donate to their loved one. Maybe they don't love them as much, I don't know. And so what is the role of that living organ donor or donor advocate? Is to then find a reason why they can't donate. Okay? Is to protect from coercion, to protect if you're taking too much of a risk health-wise, that this donation is going to actually be problematic for you. And so there's a donor's advocate. That's why they're called living donor advocate. So there's a little bit of an ethical check within the system. It's there to protect that individual who would like to donate. All right, so that's the living donor process. When we move to the flip side, the deceased donor, you have the organizations that are involved called the Organ Procurement Organizations, OPOs, right? And they're the only organizations in the United States that are authorized by a law to be part of the process, right? There are 58 OPOs in the United States. There are oftentimes, there's one or maybe a couple within each state, but that's it. They have boundary lines of where they are servicing certain communities. And they have contracts with hospital systems, transplantation systems, centers, okay? Now, we can talk about the ethics of that later on if you have a question, but I will say that there is a clear financial aspect to this. OPOs are graded in quality by how many organs they procure and how many of them are successfully transplanted. Okay, so they're rated by that. And then they're renewed. No one's been taken off, I don't think, but they've been renewed based on their quality metrics. So they actually count, right? And the people who are part of the OPOs, part of the ethical challenge is the following: that when an OPO member approaches a family member, they already have an impetus to get the organ because that's how the financial system works for their OPO. They have skin in the game financially. So the way in which they frame the conversation might be different because they want to persuade. It's not about informed decision-making necessarily, it's about persuasion, okay? And OPOs post-donation provide a lot of support to family members who've consented or authorized their family members' organs be donated, right? Their entire communities. So you'll see on our culture, there are things like, and you might have seen in the news stories, where people record, your child is going to die, they record the heartbeat, right? And then the child dies, they donate their heart to another child, and they give you a recording of the heartbeat. Huh? So you have that as a token to remember your child. I mean, they do a lot of great things. We have honor walks in our hospital, right? My point is that there's a lot more to it culturally than just being the one who procures organs. There's a whole supporting system around that. Okay, the other acronym is OPTN, the Organ Procurement Transplantation Network. These are the ones who kind of match and allocate organs to donate organs or procured organs to people who need them, all right? All right, so before the opioid, I'm gonna speed through this for a second. Before the opioid was contacted, so we said the dividing line was living and deceased, living transplantation, living donor organ, or advocate. OPO is gonna involve on deceased side. Deceased side in this context means after brain death, right? But there are people who we don't know, are they brain dead or not, yes? And the most common injury that leads to brain death is a head injury. And the most commonly, how do you get a head injury? Through traffic accidents. Hence the idea of why when you sign up for a license, you're asked about this, all right? But before the opioid gets contacted, there's a whole process of resuscitating individuals who have undergone car accidents or whatever trauma there might be. And that system isn't activated that this is a donor or not a donor. It's just a system, right? So the paramedics, I'm an emergency medicine physician, they go, they don't look, oh, is this person a donor or not a donor? They just provide care. Until you get to the hospital and you get to my ER. At my ER now, the social worker looks at, we don't even half the time know the person's name. The social worker takes the wallet out, who's their name, what's the kin, let me follow, oh, this is, then we get to know they have a DNR, don't resuscitate. Oh, maybe they're an organ donor. Only at that point, after they come to the hospital and we're doing resuscitation, do we find out anything, okay? So no one upstream to that is looking at anything. There was a system in New York City trialed that involved with figuring out upstream whether the person is an organ donor or not. It didn't take hold fully in the United States. But I'm sharing this with you because this was another push to try to increase organ donors. So what happened in New York City was that if they found out that you're an organ donor in the field, when the EMS system is there, when the ambulance is there, they would activate another system, another paramedic EMS system to take over care, to then take over care once you're declared dead so that they can preserve the organs, okay? And they would go to the organ, instead of going to the regular ER, they would go to the part of the ER that would be banned by transplantation, surgeons. They didn't take hold fully, but my point is that right now there's nothing else upstream happening. Only at the ER or post the ER do we ever think about whether someone's an organ donor or not. So all the care that one would receive is the same until at that point when we find out you're an organ donor and they've decided or they've figured out whether or not you are in the stage where you might proceed towards brain death. Or we declared you dead cardiac-wise, and then we find out whether they're an organ donor. So all these slides talk about that. So the hospital partner is mandated, right? It's usually the social worker in our setting, to contact the OPO when the person's in such a severe condition that they're going to die, or they have died, or they're going to be brain dead. We think they might have the chance of becoming brain dead. At that point, that social worker contacts the OPO. Sometimes it's a nurse, and then in the registry, they know if this person is an organ donor if they can't find it on the back of their license. Then that OPO gets involved and does a chart review to figure out whether they are eligible medically to be an organ donor or not. Okay, certain diseases you can't, certain statuses you can't. Then the OPO contacts, this is what I said, contacts the family if the person themselves aren't an organ donor on the registry or in the back of their card. So if they haven't given that authorization, they'll contact the family and proceed on that conversation only after the point when they're dead, or they're going to be declared brain dead or are declared brain dead. Okay? That's what sort of happens. Now, the thing I've highlighted here is directed donation. In the registry or in your form, if you said that we want to go again to my family first and my masjid, whatever, at that point, the OPO is going to help think about who in that circle needs it. Right? So it's a complicated process. Now, if you haven't, then it just goes to the regular pool. Okay. So as I said, now I'm just giving you the medical context. So the different decisional context, that's what happens when the OPO gets involved in potential deceased donation. In the United States, first person consent is the normative ideal. Big words, but that's what people want, basically. This is what value system-wise people say is the best thing. that you've authorized your own organs, quote unquote. We can talk about ownership Islamic if we want, but we have ownership of your organs to be donated, right? And that can be done behind the license or writing your name in the registry or even in your will. So for those who have gone through estate planning, one of the forms is about organ donations. Here's an important point. This was different when we gave the RCT in 2019. In most states in the United States now, families cannot overrule that determination. You have authorized, your word is law. I don't care what the family says. The law doesn't, I care. The law doesn't care what the family says. There were two prominent cases, one in DC, we did our RCT in DC and in Chicago, in Illinois. Two prominent cases with Muslim families that wanted to go to court because their son, both cases with son, had signed up to an organ donor. The family said, no, we can't do that. It's against our value systems. The OPO tried to convince them that this is important. But they said the law says they signed up when they got their license, they're an organ donor. End of story. Don't you want your loved one to save another person's life? Okay? Civil suit. In one case, ensued. And in the other case, the OPO decided that we're not going to go forward because we don't want to create a public, a press, what's it called? Not precedent, a fiasco in the media where the Muslim community go out and say that they're taking our loved ones' organs and they're doing this and that because they already knew that the Muslim community was not donating as much as other communities. So they didn't want to have a public relations nightmare. That's the term I was looking at. They relented, but legally they had every right to continue with the organ donation based on that, okay? So this is now, used to be very variable, but in most states, the majority of states, the exception is only those states that say no, families can have a part of the conversation, all right? That's the point of this, and then the point for us is that then we should have conversations, all right? And this is why I said in a little tweet in a little whatever WhatsApp group that if your son or daughter is going to be of age to make a decision about getting a license and you're not talking about this or they haven't talked to you about this, then you should probably have a conversation because it's important. We don't have a crisis at that moment. Okay, the last thing I already mentioned about presumed and implicit consent. Now in the UK, you don't live in the UK, but there the presumed ideal is that everybody's pro-donation and you have to must opt out, right? And then maybe in the future, this might be the case in the United States. It isn't presently, all right? But there now, families have no role. Zip. No one is asking you anything. It's individual. It's got to say, I opt out or I don't opt out, okay? All right. I'm going to pause now, all right? So now I'm going to take some questions. I've been speaking for a long time. We talked about why, right? The societal context of why there's a disparity in organs, procured organ failure. We talked about the different types of organ donation. I didn't explain them in full detail, but I gave you some sense. I gave you a little bit about the how, right? So organ program organizations involving deceased donation, living donation, transplant centers, right? And so before I move on to talking about what organs and some of the other aspects, I'm happy to take a few questions. And you gotta make easy questions. Go ahead.
No, it's a difficult question.
Okay.
So, you know, I'm obviously pro-donation because I think it saves lives.
Okay.
And also I believe, and I read the article, I think from an Islamic viewpoint, I think saving lives is important. But the question is, in the United States, most people feel like very self-centered in a way, and that's the way the society raises, people to be. And that's a little different in some of the Islamic countries where they feel like the group is more important than the individual. Is it ethically right to approach the Muslim community in a way that kidney disease, liver disease, heart disease can affect anyone? And you don't have to be like, overweight or did bad things in your life to get it, and anyone can get it. Kidney disease can happen for anyone from an infection, a medicine that they took. And then the life of that person will completely change once they have that organ failure and will come back to normal when they get an organ transplant. So that approach to people saying that it can affect affect really anyone, would that be an ethically right way of approaching that to people and saying, this is the importance of organ donation? And obviously people who have this experience, whether they have family members or themselves are affected by it, I'm sure they have likely changed their view on things, because for them this is important because that saves a life. Would that be an ethically, appropriate way of approaching that?
So if I understand correctly, you're saying that there's communitary ethic is a much more prevalent within Muslim cultures, and so as opposed to the individual, hey, like someone in your network that might need it, or you're sort of saying that this is a occurrence of any organ failure can occur to anybody, and therefore we should say that we shouldn't have communitarian-based sort of directed donation. Is that what you're saying?
Well, what I'm trying to say is that, for example, the example that you mentioned also about directed donation is very important, because I hope no one in this room gets kidney disease, but I'm sure everybody in this room knows someone who had kidney disease or had an organ failure or needed that. And in the sense that if their loved one dies, obviously, I hope that doesn't happen to anyone in an accident or something, and then they're organ donors, then the way they think about it is that, well, it is a directed donation to that person, you're saving them their life and all that. Is this approach to try to kind of approach the Muslim community, is that considered an ethical way of approaching it, or is it considered that?
I see. Well, I think I can use your point. So I think that I'll answer in this following way, that there were questions within the Muslim community in the formative work that we did around the Muslim community. I'm not saying the ulama, around, oh my God, if I donate my organ to a fasiq, I'm going to be responsible for their fisq. Or the opposite. If I'm a Muslim and I donate to a non-Muslim, they'll become Muslim because my heart's clean. And ajib sort of thinking with it, right? But these were things. No alim ever was like worried about this, but the Muslim community was. And so our approach was to talk about it, what I just did, in the sense of think about the communitarian values that you have, because people were worried that if it would go outside the community, and then within our pre-work, there was also there are fatwas, not there were also, there are existing fatwas from Muslim countries where there is this sort of notion. A Muslim should donate to a Muslim. If a Muslim dies, first look at the Muslim, then you can go to outside of Muslim. There was this clear preference of whether they're Muslim or non-Muslim. So they were used to this back home, quote unquote. And when they came here, like, well, that's why I don't know where it'll go. But I'm like, well, there's an option. You can, if you want to do that, you can then do the same thing, right? If that's of a value to you. So the conversation I'm having here, right, with Adapted was based on the ideas that were prevalent within the Muslim community. Now, ethically, it's either, hey, if I care about anybody, then why not just do it generally cool, right? But no, I know my family members, all of them when they get to a certain age, they all have kidney failure because we have this sort of problem with our kidneys. Maybe it makes sense, right? So that's an individual thing. Does that help?
So this is a question about United States, how it goes. So people who have not written anything on the license, so how does that work? They can still ask the family to donate?
They will.
As compared to the one who has said, no, I do not want. So
There's no on the back of your license.
no, but can you add that?
No, you can't.
No.
So the no you can write is like into your will after you die, right? But the only no would be if you talk to your family. You could write it and you're gonna have that form, right? You're not gonna carry it with you when you're driving or whatever else it might be, right? But the repository of knowledge would be your family members. So the point is, if you've written something, that's enacted. If you've not written anything that your family's asked, if your family doesn't know, they'll have a conversation amongst it, and someone's got to figure out what they wanted to do or not do, and they'll make a decision for you. Which is why I said there can be problems at the moments of crisis. Your family member just died, or is dying. At that moment, you're going to ask all these things. Just think about that. Like the emotional state of some family member already dealing with this whole thing, this crisis happening, all of a sudden someone's asking, well, are they donor? Are they not know which donor? I mean, it's just a really difficult thing, right? With all the other things that are happening, managing a family that's breaking apart. And I'm asking you as an emphasis to spare that harm or emotional turmoil by making a decision yourself if you can. Or at least have the conversation so no one's going to So I want to get into that in a second. So I'm going to get into that in a second. Some of that, you're probably asking a deeper question, and we can get to that. But um, it depends. There's a whole construct. I think it's the community setting. You talk about warmest humid time versus coldest humid time, all this stuff. But it's time limited. Let's just say that. And it depends which organ. It depends kind of. It's an urgent situation because of this notion of the outcomes that occur post donation. And there's I'm gonna get into some interesting scenarios in a second. So let me do this so that we don't get into Isha. Okay. So what organs can be donated, right? That's sort of the next question. What organs can be donated? And so this is a chart where I've listed almost everything. So first, obviously, right, and they've differentiated between deceased and living. Now, deceased is in quotes because I told you the notion of brain death is problematic, potentially from a religious perspective, okay? But in the context of this chart, and so far what I've talking about today is deceased would be post-brain death, could also be post-cardiac death, but at least post-brain death when this time starts. So the heart can be donated after you're declared dead. Obviously, when you're living, you can't go, I'm going to give my heart to someone right now, take it out of my body, because you would die, right? Lungs, however, obviously after death, but you can give partial lung, you can even give one lung, potentially, because you have twinned, right? And liver, partial liver you can while you're living, obviously after death. Pancreas, you can give after death, not while living. Kidneys, again, you can give after death. You can also give while living, if you have paired kidneys, potential, right? 2 kidneys. Your intestine, you can't give while living, but after death, they can take parts of your intestine if it's viable. Cornea, after death, not while living, right? Makes sense. Okay. Then I talked about these vascular composite allografts, VCAs. Face, uterus, hand. The whole thing. Tissue plus organ tissue vessels. So there's a specific authorization that's required in the United States presently. If you sign the back of your card, your license, they can't take these things, okay? Face, hand, and uterus yet. There's a push to try to do that, but yet they can't. As of yet, they can't. You have a specific authorization to do that, and it's typically after death, not while living, okay? Sperm, ova, and even embryo. This is an extra market solution. It involves the healthcare system, but actually it involves companies without the healthcare system. That you can donate sperm, an unfertilized egg, or a fertilized egg. Okay? Now just know that Sunni Islam would prohibit all those things. We're going to get into that in a few, 2 weeks from now. But and why? But nonetheless, this is a special market solution in the consumerist culture that is medicine here in the United States today. Tissue, bones, and tendons, you can potentially do it while you're living. In the case of your own body, you do it when you're living, but mostly it's after death, okay? And in that case, it's the organ procurement organization in your region that actually has facilities to facilitate tissue. They can procure tissue after death in their own labs over there. It's a special process that occurs. It doesn't necessarily have to be within a hospital only. Okay, so that's the extensive list. Okay. Yeah. All right. So let's move forward. Now, you asked kind of some people ask, so how are you matching? There's a lot of issues in matching. It depends on which organ you're talking about. Some don't need matching. One thing I left out here, I forgot, is blood. Blood is also an organ. We donate that all the time, right? You can go and do it both within the healthcare system or outside of the healthcare system. Okay. So blood type has to be compatible. Size sometimes, depending on the organ, and you can't give a child an organ of an adult sometimes, and vice versa is actually the more problematic, giving an adult the child's organ. Geography, right, time between recovery and transplant, how soon can you get people because of the ischemia time. And then there's the urgency. For heart, liver, and lung cancers, this is like time critical and time sensitive. This is where people are on flights, right, to the transplant center, and the organ is also on a flight to get there, or on a helicopter to get there, right? So that's and then the whole team. So a friend of mine, he did the first triple transplantation in Dubai, So the heart was coming from here, lungs from there. It was just a whole fiasco. And all of it was by, I think, Emirates. They had a whole photo op that we flew all these things together to get to Dubai to save someone's life. Okay, so it's a really time urgent thing. And then the issue for kidney is all about time, where people die while waiting for kidneys. So the common misperceptions are the following. I'm just going to list them here, right? That some people say that if they see I'm a donor on the back of my card or whatever else it is, the hospital won't try to save my life. That's a myth. That's not true. I'm an ER doctor. I've practiced for 18 years. That's not the case. We don't even know half the time. We don't even know your name, much less whether you're an organ donor. All right. My family will be harmed, and a member will be harmed and disfigured. Now, this is not necessarily mythic. The body of someone whose organs have been procured, when you look at that body and you do the ghusl, is different, looks different. At least has scars. You can tell, okay? Then one is not. Now, they're going to try to be respectful and all this stuff, but if you have 4 organs removed, you will see the scars of that. If you have bones taken off, you will see that. This is reality. So, and we as a community, Islamically, don't do all the stuff other communities do at the caretaker house, right? And they put makeup on, and we don't do any of that, right? We don't do that. So my point is that it will look different, but it's not that they're disfiguring and mutilating them purposefully. My family will have to pay for a donation. That's not true. In the United States, if you have insurance, then the insurance of the one who has failure will pay for the donation surgery for the donor. If I'm in a coma, they'll take my organs. That's not also true. Coma is not the same thing as brain death. And then someone can take my organs and sell them on the black market. That occurs in many places. In the United States, it doesn't occur. But it occurs elsewhere. So federal law here prohibits that. So I'm going to move to living donation for a moment. So why living donation? Right? Why not just all deceased? Because living donation works better, particularly for kidneys, for others mostly as well, right? There are fewer complications. And a living donor, meaning someone the donor is living and they donate to you, it lasts longer typically, 18 years versus 12 years. Okay? That data is now changing. Specialized centers, for example, in Albany, they've found almost equivocal rates of longevity between a donor that's deceased in hospital and a living donor. But they're in hospital. That's a big qualification, okay? So that's living donation for kidneys. Also, it eliminates for the person who is failing, has a kidney that's failing already, they have less time than on dialysis and the wait list, right? As I mentioned here, some people wait up to 5 years for a kidney. This is what was in Chicago. And 12 people who have kidney failure die every day while waiting on the transplant list. Who can be a living donor? You have to be an adult, so over 18, age of majority in the United States, and usually under 70 because of comorbidities. You must be able to make an informed and voluntary decision yourself. So this is a first-person authorization, so you have to understand risks and benefits, can't be receiving money, and can't be pressured. The living donor or advocate within the transplantation center is charged to make sure all these things are the case. And then you can't have a lot of health comorbidities, right? So you can't have high blood pressure, or if you have high blood pressure, it's managed by just one med. Can't have diabetes, cancer, kidney disease, or like HIV. Can't be a drug abuse, so to speak, right? Or uncontrolled depression. And usually you can be overweight, but you can't be obese. So these are all the qualifications. I'm sharing this with you just to let you know that it's not everybody. It's a certain type of person who can be a living donor. And now there are costs. I mentioned to you that our program is about we're not just talking about trying to sell you something, but you have to know what the risks and costs are. So obviously, if you're going to donate your kidney, you have to have a lot of medical tests, or if you're going to donate your liver or whatever else, right? That takes time, takes visits to the medical center, and there's follow-ups after you've done that donation. Recovery from a surgery can take time. 4 weeks, 12 weeks, can be even more. You can even, right? So this means you have to take off of work, and you can't do certain types of activity after. They say about pregnancy because it also causes some physiological stress upon the body. And then you can have an infection, or any surgery, infection, pain can be a complication. And this is just a general estimate about lost wages, $3,000, right? So there are some costs, physical costs, fiscal costs to donating. So it's not just a no harm process. This is another important one. we are medicine's empirical-based specialty, and we have these calculators here. You can go and look up and put your own, it's cut off, put up your own risk in these sort of qualifications, right? We'll raise some, and it'll tell you if you were to donate your kidney, what's your risk of having failure after that. It is true that if you donate your kidney, you're at a higher risk of having kidney failure. True. But true to like this extent. It goes from general population risk 24% to 1.02%, right? So I can say you have a fourfold increase in risk of having kidney failure, but the absolute numbers are quite small. But this is true, right? And depending on your own characteristics, it might actually be more than 1%. And this is the job of the organ donor advocate, is to go through this calculation with you and make you understand that this is real, right? And then you only have one kidney left. And if it fails, you'll be in the same position. The good news is if you're in the same position, you have kidney failure after you've donated, you're a higher priority. They give you something about that. All right. So this is just the short and long-term outcomes, right? The complication risks are very low in the short term. People have died. When I was training in New York City at Cornell, Mount Sinai, this program was shut down because of a liver donor who died on the table. Any surgery can involve risk. Not common, rare, but reality. Long-term donors are at risk, as I mentioned, for kidney failure, for hypertension and preeclampsia, for those who are thinking about getting pregnant. And as I said, if you develop kidney failure, then you have a higher priority for transplantation. So the point is that there are risks. Oftentimes in programs, people don't tell you that. Like it's all no problem. But the reality to make an informed choice, you have to understand that there are some risks and there's some qualifications. Not everybody can do it. Now, the benefits, this is not really a benefit, but the point of this is a benefit that, as I said, the surgery and the evaluation is paid for by the person who's going to get the organ. Their insurance, and if they don't have insurance, that's a problem. They can't get on the list, and then no one's going to pay for the donor. And you can potentially use medical leave at your different employing agency. Different employers have different policies around that. I mentioned already that how you start that process for living donations, get to the transplant center, and that's how it usually works. All right. Last before we close. Okay. Now, I mentioned all those other things about donations, not one thing, but now specifically a kidney donation, living kidney donation is not one thing either, it's multiple things. So you can give directed, related, you asked the question about, so to a family member, or unrelated, right, directed, meaning I'm going to give to a specific person who's a friend or spouse or my mosque community member, okay? So it could be unrelated but directed, or it could be to anybody who needs it, right, non-directed. So I already mentioned this idea. But what we have, an interesting phenomenon that started over a decade ago now, was this idea of chains. That you have a family member who needs a kidney. You're not a match, but you're willing to donate. You go through the process, you want to donate. You can initiate a chain by which you donate your kidney, and depending on the chain, someone out there who is in your situation, whose family member needs a kidney, will donate their kidney that will come back to your family member. Those chains can get very complicated, but they're managed. So it's this chain phenomenon by which a non-directed donor, right, is not directed, but they go through and it gets to your family member, okay? And it's going to be very complex, but it's managed. So it's sometimes it's two pair, three pair. But there's a phenomenon, particularly around kidney donation, which the person who created this won a lot of praise, because now people can, previously, right, you have someone who's wanting to donate, but then they won't donate. Now they do still donate, and you help the entire society through these chains. All right, and then, yes. So the other thing I want to reinforce again, that in the context here of living versus deceased is brain death. So there's different pathways, right? So if you have brain death, we'll talk about that next time Islamically. But the proper term is, you've met neurological criteria for death, someone certifies that, patient declared dead, then organ donation takes place, right? Or cardiac circulatory death, cardiac arrest, and then that's how organ donation takes place. So those are both deceased now, right? But the dividing line is usually up here after brain death, because that precedes oftentimes, in this scenario, it precedes circulatory death. But what I wanted to share with you is the following, because we're in Wisconsin. This is UW Health. There's these protocols for donation after cardiac death that occur. There's different types, the master classification, controlled, uncontrolled. But this is an emerging phenomenon to try to increase donation. And this is a tricky area ethically, both in the secular world and the religious world. So what happens is that, you have an individual in the controlled setting in the ICU who is peri-death, right? There's no treatment that's going to help them recover. They are peri-death, right? They're at the end stage of life. Fetal care is going to be delivered, long-term process support. So the family then might say, hey, we want to be able to, or the person themselves might say, I want to be an organ donor. What can we do? So you would withdraw life support. And when you withdraw life support, referrals made to the OPO that there's a potential donor, right? They become withdraw life support. So that withdrawal happens of the ventilator, person's heart's still beating, and you go either to the operating or, it usually happens in the ICU, but you go to the operating room and you see, and you wait, and you count the timer if their heart's gonna stop after the tube is taken out. Now, UW here has 5 minutes, there are centers that have 2 minutes. So if the heart stops, then you put a timer for 2 minutes or 5 minutes, some places 8. And you allow that person, and you call that person dead at that point. The person's already DNR, so you're not going to, in DNI, you're not going to intubate again, you're not going to do chest compressions. After that 5 minutes stops, the clock has hit, then depending where you are, they don't list it here, but you might have already put in some medication, like a blood thinner, to make sure that the organs don't fail, right? You might have put in some other medication, you might have cross-clamped the aorta, but you restart the heart. And you make sure that there's no flow to the brain, and then you procure the organs. Okay? And the surgery takes place. So they're declared dead, the heart has stopped. 5 minutes later, the heart's there, still beating now, because we resuscitated it and the organs are taken away. And this is very controversial, but real. Happens now, just an hour and a half away, 70-some miles. So we'll talk about the Islamic notions of this later on, but fuqaha, again, the context, right? I told you today all about context. There's no fatwa. You're not going to find any fatwa about DCDD. You're going to find fatwas on organ donation is okay or it's not okay. But it's a very complex phenomenon with multiple steps here. And what's not okay? Declaring someone dead at 5 minutes, putting in a medication to stop them from, or putting cross-clamping the aorta so the brain doesn't get any blood flow? Like, what is haram here? What's halal here? All of this is not necessarily spelled out. So again, one size doesn't fit all. Living versus deceased is based on brain death. I just talked about DCD, directed, non-directed, life-enhancing, life-preserving, or life-giving, organs plus tissues, organs plus tissues plus vessels, and consent. So that was the goal today. We're going to go next time, inshallah, into the Islam component. But I see it took 49 minutes to just get through the context, inshallah ta'ala. The floor is open before we go to Isha, inshallah, we can chat. Barakallahu feekum. Yes, sir. Can I give someone else a chance first?
Absolutely.
Please, fadlan.
So did you find any specific issues in the Muslim community versus the general population why they were not as interested in organ donation?
Are there reasons within the Muslim community? Yeah, there are many reasons. So I didn't show you the slides. One of them is their question of whether the Islamic tradition permits or doesn't permit. There are questions around, I mentioned, around the notion that someone who you donate to, are you going to be responsible for their sins after? No is the answer to that, but these were concerns in the community. There are concerns in the community around modesty issues, that when I'm going to donate, if I'm a female after death, there's still a hurma of the body. Oh my God, is that modesty going to be taken care of or not? Right? There are issues around if we're going to go and bury the individual, right? What do they look like? There were concerns because there are people within our community who have seen what happens to body and say, well, this is mutilation. We don't want to go for that way. So these were the concerns. It wasn't just an Islamic sort of what Islam have to say, but there were multiple cultural also concerns around what was happening. I have a whole paper on that, and I didn't put the slide in here, but there were specific things within the Muslim community that must need to be addressed and talked about, that oftentimes wouldn't be, you can't find that in a pamphlet, right? You'd have these generic pamphlets, Islam says okay, which is why we dropped ours, because that's not the issues in our community. Yes?
So, one of the things that are very particular about the transplant is its ethical background, even at any community.
Uh-huh.
You know what I mean? And a lot of it has to do with the details. So, I guess, because this is also a moving target, how Muslims community are going to follow on this?
How the Muslim community are gonna,
Are going to follow on the changes that even happen at the science and the ethics
Right.
of the transplant.
how? Yeah, by things like this maybe? By having conversations, by having people who have to think about what their religious leaders say. I mean, many Muslims don't care at all, right? What anybody has said. So that's one way. The interesting thing is that I would have hoped, but we have many, Saudi Arabia has a huge transplantation program. Iran has, and we're not talking about Shia Islam next time, but they have a huge, I mean, their countries have huge transplantation programs. They've thought about these sorts of things to the extent that the population knows what's going on. There's a dissonance between what the physicians know and what the fuqaha are thinking about, and all of a sudden what the population thinks, right? Because for them, it's like if the fuqaha have said, okay, khalas, I don't have to think about it. For us, actually, we have to think about it more, because we don't just take as a given that the system is going to be Islamic. For them, it's a little easier that if they've said it, then we don't have to worry about it. For us, it's much more nuanced. So I think our burden is higher because of all this. And the science here is what's driving the changes there technologically, right? It's imported from us. So I think that's the other phenomenon. So how? It's in Islamic medicine, we try to do these sorts of things to actually be up to date, data driven from the science, and then we can have particular questions. One of the interesting phenomena when we're doing the review of fatwas was the following: that every fatwa is based on the framing of the questioner. So here's the questioner would said in the fatwa to a fuqaha, to a faqih, we have all these people, all these patients in the ICU that we can do nothing for. And they just are eating up our resources, their family members are crying, there's nothing to do for them, but just next door in the other ICU, there are people whose kidneys are failing. Do you think it's okay for us to kind of, promote donation and tell their families that, we should make a donor? Oh, this is wonderful. You're salvaging something from a bad situation. We have these people in the, that's the response. We have these people in the, people who are dead. And we want to now take their organs. Is that halal? No. Haram. What was the difference? There was no difference in the scenario. It was the framing. Because at one stage in the ICU, you cleared them dead when they're brain dead. He was talking about the same scenario. But the questioner, the way they said it, led to a different ruling by the faqih. My point is that we have to be better ethically about how we're framing the question. The faqih doesn't know all this stuff necessarily. So with the Fiqh Council, I had 2 years of consultation. I was involved. We went to 4 meetings. Because it was like, I'm like, look, this is much more complicated than you think. Yeah? And so it requires honesty from both the people. I mean, we're part of the system. I'm a physician. But we have to be honest. If you really want religious scholars, they have to understand and speak the same language. And let's talk about it. And then, inshallah, maybe they can provide us guidance, right? Anything else before? Yeah.
I think you already talked about it, but I wanted to go on a little bit of a tangent.
Uh-oh. Okay. Fadal.
So organ donor is one thing, but donating body to like hospitals or even to educational institutes.
Yeah.
Because at the end of the day, I mean, those doctors are going to save many lives. And,
Yes. So I will tell you, yes. If you bring that up next time, actually there's a whole interest. I didn't put the slides in. But if you bring them up next time, inshallah, they come 2 weeks from now, I'll talk about that. Because there were some interesting fatwas that came out of Malaysia on this specific topic. The quick response is the following, that traditionally the body has hurma, whether it's living or dead, so no. Right? But then there was an exemption by fuqaha, for some fuqaha, for purposes that are necessary, and within that they considered, hey, this is fard ayn to have doctors in our society. It's for the kafaya to have doctors in our society, and so they need to learn, there's no other modality to learn, so by darura, okay. When now we have data that shows that we can use models, computer simulated models, and MRIs to show anatomy, right? This is being questioned again, right? Because that ruling, because there was no other modality of learning, and that modality of learning was no good. If you're going to go do a cat, it's not the same as a human, right? But now we actually have technologies in non-Muslim countries that they decided we don't have enough donors. We're just going to use MRIs to show the anatomy, to use pathology lab. We already have stills from pathology lab. We're going to do models to simulate things, and that's sufficient. And then they do testing between different classes, and they find that they learn the same. But the fuqaha still say in Muslim countries, oh, it's exception. So anyway, that's it. Malaysia is now taking some interesting looks at this. Inshallah, we can talk about it. I think Isha is in 5 minutes. People probably have to make wudu. If someone wants to make a line upstairs, I have their mic. So, barakallahu feekum, inshallah. We'll see you in 2 weeks, where then we'll talk about Islam. Jazakallah khair. Assalamu alaikum. And again, you can take the material that I've left out there that's free for free.